Hey everyone, my name is Vunami. I am a third-year pharmacy student, and today's journal club presentation will be about Letermovir prophylaxis for Cytomegalovirus and Hematopoietic-Cell transplantation, published in the New England Journal of Medicine in 2017. So I will, just for fluency of the presentation, I will abbreviate Cytomegalovirus as CMV and Hematopoietic-Cell transplantation as HCT. So our objectives today is to describe the background of CMV and HCT, identify the guideline recommendations from the ASTCT 2021 guideline for the prevention of CMV infection and disease after hematopoietic cell transplantation. We'll also describe some of the sections of this phase 3 trial with the use of Letermovir. So just as a background and relevant definitions and abbreviations before we tackle the paper, HCT is essentially the idea of transplanting stem cells. So stem cells have various sources. They can come from the umbilical cord, which is called cord blood. It can come from the bone marrow, where we have aspiration of the hip bone, where we collect fluid there and then isolate stem cells from there. Same applies for umbilical cord, where we are pulling fluid from the umbilical cord after birth, and then we are isolating stem cells to be provided to a patient recipient. Peripheral blood is the more common method of gathering stem cells, as it uses an apheresis machine. And I'll show you that machine soon, but the machine essentially collects stem cells and returns the remainder of the cells into circulation, into your own circulation. HLA, or human leukocyte antigen, are human markers that are found on the cell to recognize which cells belong in the body and which do not. So you can imagine if you have matched HLA in terms of stem cells, then you would have less likelihood of getting immune reactivity, if that makes sense, so immune issues. So for example, graft versus host disease is when the stem cells are attacking the recipient after HCT. So if you have matched HLA, then you are less likely to have this condition, but it's a common complication for patients having HCT. And I think that one of the main form of therapy is prednisone or corticosteroids. In terms of engraftment, so what is engraftment? It's the time when the stem cells actually activate, when they actually provide that proliferative effect of forming those newly formed red blood cells, white blood cells, platelets, after the transplantation of stem cells. So at what point after receiving stem cells do you actually get this proliferative effect? It would be approximately 7 to 14 days typically, but let's look further into the background. So if I want to direct you to this top part of the screen. So the top right corner, you'll see an apheresis machine that is grabbing peripheral blood from one arm to isolate stem cells into the machine. And then the rest of that blood is going to be circulating back into the other arm. Okay, so this is from a donor. So allogeneic. Autologous is when you give yourself your stem cells. But this is allogeneic, so this is a different patient where the recipient is receiving chemotherapy first before receiving stem cells to rejuvenate, those white blood cells, red blood cells, etc. So what is cytomegalovirus? Well, for just as an FYI, more than 50% of adults in the U.S. who are over the age of 40 have CMV, but it's latent, it's dormant. So they are asymptomatic in these healthy individuals. But if you are immunocompromised, then these opportunistic pathogens would be an issue for immunocompromised patients. So a lot of these adults, they are latent, but also known as seropositive. So in a test called ELISA can detect the IgG that is CMV specific, which determines that you are seropositive for CMV. You're seronegative if we don't have that detection of IgG in your blood. And the IgG is specific to CMV. And active infection just means you have viremia of CMV, and that CMV is likely to cause complications such as pneumonia, colitis, and retinitis. So the most frequent complication is graft versus host disease, but what other complications are there after HCT? There's VZV, so varicella zoster virus. There's also herpes simplex virus. And there's CMV. So we need prophylactic for all of these conditions. And for GVHD, we use prednisone, like I mentioned before. I think it's in the form of 1 mg per kg per day. I'm not sure. Don't quote me on that. But other therapies are going to be acyclovir or famciclovir or valacyclovir when we are doing prophylactic therapy for VZV and HSV. All right, so lots of abbreviations there. But what do we do for patients who are seropositive CMV patients for CMV prophylaxis? Letermovir is our drug of interest for the study. And typically, for the past 20 years, there's preemptive strategy or preemptive therapy to detect CMV at a specific threshold. So a viral load of CMV in the blood would trigger the administration of antiviral treatment. And I think specifically that viral load has to be over 1,000 units per mLs. But the use of these antiviral medications such as ganciclovir or valganciclovir still causes increased mortality. So we do definitely need an effective and safe antiviral agent for CMV prophylaxis. And letermovir seems to be that drug of choice. So if we look at this trial design, 565 patients in a phase 3 double-blind placebo-controlled trial comparing letermovir versus placebo in a 2-to-1 ratio funded by Merck. In this study, called Letermovir Prophylaxis for Cytomegalovirus and Hematopoietic-Cell Transplantation, we are determining if letermovir is efficacious and safe as prophylactic therapy against patients who are seropositive for CMV and is going through that HCT. And it has to be within 28 days of HCT. All right, so the null hypothesis is that there's no statistically significant difference in the development of clinically significant CMV infection through week 24 after HCT for those who received letermovir intervention versus those who received placebo. So this is a figure I made just showing us that 738 patients were assessed for eligibility. 570 patients underwent randomization, and there were many that were excluded due to being CMV seronegative, due to having already received anti-CMV antiviral agents, or had viremia of CMV. Other exclusions include severe hepatic insufficiency. There's previous allogeneic HCT. We want to make sure that this is generalizable to not the public, but to patients with to this patient population of having their first HCT. So inclusions are going to be involved, well, it's going to be just young adults, 18 years or older, undergoing their first allogeneic HCT. They have to be CMV seropositive, so that means latent CMV. And specifically, it must be within 28 days post-HCT at the time of randomization. So it's a very specific time frame. So I guess I can imagine why the sample size is a little bit lower than I expected. I think it was around 700 or 500. Okay, and then when we look at the patient baseline characteristics here, more than 80% of Caucasians are in both groups, letermovir and placebo group. Others are Asian, but only at 10%. And there are primary reasons for HCT. Leukemia, lymphoma are some of the reasons I mentioned before, but there's other malignant conditions that patients have that as a reason for HCT. HLA matching is related, it's relevant, because if patients are receiving mismatched HLA, then they are at high risk of having CMV disease. The same applies for those who received stem cells from a certain source, and that source is cord blood. So if you received umbilical cord blood that has stem cells, then yes, you are at high risk for CMV disease as well. Another defined category, not another defined category, but what also makes you at high risk for CMV disease is if you had grade 2 or higher GVHD. Now let's look at some outcomes. So primary outcome, which is the important ones, Percent of patients with clinically significant CMV infection up to week 24 post-HCT. So what is clinically significant CMV infection? It's defined by 2 points. Either or works. So either you have an onset of CMV and organ disease. So that disease is essentially a manifestation of CMV infection, such as pneumonia from CMV or retinitis from CMV or colitis from CMV. Or the patient has gone through initiation of preemptive therapy, as I mentioned before, with the use of ganciclovir. All right, and secondary outcome involves basically the same outcome as the primary, but shorter in duration over here. So percent of patients with CMV infection up to week 14 post-HCT, but also the percent of patients with CMV and organ disease up to week 24 post-HCT. Other measured outcomes include percent of patients discontinued from Letermovir due to adverse drug event up to week 14 post-HCT. Now another outcome that I didn't mention yet is the all-cause mortality using the Kaplan-Meier plot. I'll show you that soon, but it does a good job in measuring that all-cause mortality for 48 weeks. And so the intervention is Letermovir, 480 milligram per day via IV or PO versus placebo for 14 weeks. So the treatment, the use of Letermovir only lasts for 14 weeks. But the whole study actually lasts for 48 weeks. I think that's a great idea. Even though we finished treatment duration, we are still doing follow-up. And that's to look into adverse drug events, all-cause mortality, and still looking at that CMV DNA PCR to detect if the patient has clinically significant CMV infection. All right, and so we start off with measuring that CMV DNA PCR weekly up until week 14, every 2 weeks up until week 24, and every other month until week 48. This is just another overview of the methods that we used for safety analysis. So collecting the safety parameters for 16 weeks, because treatment period is 14 weeks, and then 14 more days after that is 16 weeks. And we are looking at essentially parameters that are assessed by clinical review in regards to lab tests, vitals, EKG, and adverse drug events. And they have something called a three-tiered approach, where we're just using two-tiered and three-tiered. We're not using one-tiered because from what they stated, it's inferential testing, so that's why we're not using it. But looking at statistical analysis here, we have our current sample size is appropriate. It provided us with 90.5% overall power, which is over 90% power in primary efficacy analysis. So at the end of the trial, the one-sided p-value that is less than or equal to 0.02 will be used for declaring efficacy success. So some of the methods used for endpoints were Cochrane-Mantel-Hansel, Kaplan-Meier plot, and the Miettinen-Nurminen method. So I've never heard of the Miettinen-Nurminen method, but they stated that they used it to collect average drug event and putting into consideration the 95% confidence interval. All right, and the Cochrane-Mantel-Hansel does a good job in essentially generating an estimate of an association between exposure, which is Letermovir, and the outcome, which is clinically significant CMV infection, after adjusting for confounding variables. The Kaplan-Meier plot, I'll show you that pretty soon, but they do a good job in plotting data points, and when we compare Letermovir versus placebo in regards to clinically significant CMV as well as all-cause mortality. But let's look at some endpoints here. All right, so primary endpoint of clinically significant CMV infection at week 24 after HCT. So after using Letermovir for 14 weeks and then we go up to 24 weeks, we see that Letermovir did decrease, statistically significantly decreased clinically significant CMV infection by 23.5% because the p-value is less than 0.02. Now the secondary endpoint provides us at week 14 after HCT that Letermovir provides an even more impressive value or statistically significant decrease in clinically significant CMV infection by 31.3% when compared to placebo. because the p-value is actually less than 0.02%. Now, this is just a Kaplan-Meier plot that further clarifies that Letermovir does provide that benefit of cumulative rate of infection lower than placebo. Sorry, I want to clarify that Letermovir has a lower cumulative rate of infection than compared to placebo in high-risk group and the low-risk group as well. But I also want to mention that if you look over here, at 18 weeks, Letermovir seems to have a little bit of an increased rate of infection, of CMV infection, that's clinically significant. And we know that the Letermovir treatment duration is up to 14 weeks. So I may want to consider the idea of extending Letermovir treatment duration up to 24 weeks. What do you think about that? I think that's interesting. I think it may be something the future studies should look into, or maybe previous studies have already considered this. Maybe we're doing this at another phase. Who knows? Guess we'll see. But the all-cause mortality here, shown by a Kaplan-Meier plot, provide us with information about high-risk group versus low-risk subgroup. So remember that the high-risk subgroup included those who had grade 2 GVHD or higher, or for those who received stem cells from cord blood, or for those who actually got mismatched HLA. Now, if you look at the high-risk subgroup, you can see here that there's a bigger distance between Letermovir and placebo compared to low-risk subgroup. So I can say here that for patients who are from the high-risk subgroup category, that they will benefit more with the use of Letermovir compared to that of low-risk subgroup. I know that they both benefit, but relatively, if we look at the high-risk group, they would benefit more. And I think that this is probably put into consideration when we think about the cost of Letermovir, because Letermovir is pretty expensive. It's around 25 to 49 grand for a whole treatment course. So you can imagine maybe they might prioritize high-risk subgroups when we use Letermovir. Now let's look at adverse events. So Letermovir and placebo, if you look down the list here, it seems that Letermovir is well tolerated. It seems that that the numbers, the percentage of adverse effects and specified vomiting or edema seems to be generally the same. I know there's a little bit of an increase in incidence for vomiting and edema for Letermovir group, but it's not statistically significant. So I would say that Letermovir is pretty well tolerated. And you may try to ask yourself, why is the placebo group getting adverse events as well? It's because these patients, all of these patients in this study have gone through HCT just recently, within the last 28 days. So you can best be assured that they are receiving some form of adverse event from that transplantation. The actual strength that I think is pretty significant in this study is that the 48-week follow-up for monitoring parameters is definitely a good idea, because we were able to see the all-cause mortality for up to 48 weeks, and it provided us some insight into high-risk versus low-risk subgroups who are seropositive for CMV patients. And also, we saw up to 48 weeks, the clinically significant CMV infection was still lower for the Letermovir group, even though the Letermovir treatment duration was only up to 14 weeks. So it's definitely helpful to see that in this study. And we also measured for adverse drug events as well. Both groups basically had similar baseline characteristics if we kind of go back to that black chart. So this provided us a percentage that is very similar to the other group. So Letermovir, 38% had acute myeloid leukemia, but also 37% in the placebo group. And generally, the percentages are all the same or very similar in both groups. So it was well balanced, which is what I'm trying to say. And so if we look at weaknesses, over 80% of the population for both groups were Caucasian. I think that increasing the sample size will provide some diversity. So I think that future studies should really try to gather more participants, even though I might be asking for too much, considering that Only 20,000 patients per year receive HCT in the United States. And considering that we have around 700 subjects in this study, I think that we did grab a good amount. But I think that grabbing more would improve the study. So other weaknesses involve the oral and IV formulations. So when I looked into this paper, it seems that patients who are taking oral or IV were just placed in the same category. Like if we were to look at adverse drug event monitoring, they were just placed in the same group. So I would assume that for patients who are receiving oral Letermovir, that they would probably get more of a GI side effect, GI adverse event, compared to those who are in the IV formulation, who received IV formulation. It's interesting. I think that future research or other research may be looking into this. Pharmacokinetically, I think that maybe there's an assumption that the oral version of Letermovir had high bioavailability, which is why the same dosage for either formulation was appropriate. But I don't think it's going to be 100% bioavailability. You know what I mean? So it's interesting to see that in this study. But in conclusion, Letermovir as prophylactic therapy against CMV provided that clinically significant CMV infection prevention for those who have undergone HCT within 28 days, and when we use that Letermovir for at least 100 days after HCT compared to placebo. We saw that Letermovir toxicity was kind of mild. It was pretty mild, pretty similar to placebo group overall, and that there's definitely lower all-cause mortality with Letermovir compared to placebo at both week 24 and at week 48 post-HCT. For future studies, I think that using Letermovir in pediatric patients may be not warranted, but should be considered because pediatric patients do undergo HCT as well, and CMV prophylaxis may be necessary in this patient population. But also prophylactic therapy for CMV in patients who are undergoing solid organ transplantation may be warranted as well. I just want to see research involved with that because we are in a very specified patient population of HCT and a very specified time frame of 28 days after HCT. So I was very interested in why they chose 28 days. You know, it could be just due to maybe fundamental pathology of what happens when you receive HCT and maybe when CMV infection occurs. But it's interesting to see that. But the results of this phase 3 trial did provide us with Letermovir being FDA approved because this is an unmet medical need for new CMV prophylactic treatment. So Letermovir is FDA approved to be used in adults who are CMV seropositive from allogeneic HCT recipients no later than 28 days after HCT and continuing through day 100. It's a mouthful, but with this specific patient population, it's the same as the study. The indication is there. So it's there. So we're excited. It's here. And if you do have any questions, feel free to comment down below. But I